This is Radio Brockley.
Hello and welcome to Brockley News Extra, the programme where you get the chance to hear all you need to know about what's happening in and around the hospital, as well as updates on other local events and people who work in the community. I'm Alan Joyce, and coming up today we'll be hearing from the hospital's Chief Executive, Rob Hurd, in an extended interview with our reporter Keith Reeve. Over the next hour, we'll be hearing updates on the hospital's redevelopment, as well as some of the other challenges facing the hospital in the last 12 months. He also gives us an in-depth update on the workings of the RNOH. Don't forget, Radio Brockley is with you 24 hours a day, 7 days a week, so stay tuned to London's longest-running hospital radio station and your number one recuperation station, Radio Brockley.
My name is Keith Reeve, and it's my pleasure to welcome back to Radio Brockley Rob Hurd, who is the RNOH Chief Executive, who has kindly spared some of his very precious time to speak to me today. Welcome, Rob.
Thank you very much for having me again on Radio Brockley.
It's a pleasure, thank you. You'll be pleased to know that this time we've got no questions about car parking or the food.
Fantastic, yes, I'm glad it's all sorted.
But obviously it's about 18 months or so since we spoke to you last. Lots of things have happened in that time. One of the big things, of course, this year was the Quality Care Commission's report on the hospital. Now, the Trust invited in the CQC
We did.
To report on the hospital. But unfortunately, despite some outstanding practice highlighted in the report, the overall outcome, unfortunately, was needs improvement. Now, this is obviously not what we wanted, but was it actually a shock to the Trust management?
Well, as you say, Keith, we were keen to bring the CQC in because this was going to help us sort of keeping the organisation moving forward in terms of rebuild foundation trust status. And as the CQC reflected, we have a lot of pride in outstanding care, outstanding effectiveness of the services that we provide. So there's no real surprises there. And indeed, if you sort of look at us against other hospitals, we until recently we had more outstanding ratings than any other hospital that's been inspected in this way by the Care Quality Commission. I think Frimley Park recently have overtaken us and got an overall outstanding, which was very impressive. So on the care side of things, the effectiveness of outcomes that we get for patients, as I've said to you many times before here, the RNOH is a special place and gets good outcomes. Now, we never went into that process claiming that our buildings didn't need improvement, and they found in particular some of the isolation of the children's ward and some aspects around the children's facilities were inadequate. By our own admission, they are inadequate and need improving. That's why we need to rebuild the hospital. So that wasn't a surprise at all that the facilities were there. Perhaps that when weighting off the outstanding care, outstanding effectiveness of our clinical services against some of the other issues, it isn't acceptable that we don't have our WHO checklists 100% of the time. We do now. We didn't when they came and inspected. It isn't acceptable that some of our equipment they found not to have been up to date in terms of its inspection, checking it was working. So I don't defend those things. I think in a large organisation you will generally find examples of that, and we strive to do better in those areas. And I suppose the disappointment and surprise, if you like, was that the weighting overall from some of those things against at the end of the day, we're a hospital providing outstanding care and effective care for patients, albeit in a very difficult environment. We were hoping that would weigh up to a bottom right-hand corner rating of good. They weighed it up to a bottom right-hand corner rating of requires improvement, and said they'd come back and look at those areas that we are able to do something about in the immediate term, and if we've sorted those out, upgrade the rating.
You touched on the WHO checklist there, just to make it clear. It's a World Health Organisation surgical safety checklist, is that right? That's
right, yes.
And that's been fixed?
Yeah, so I mean, it's a general requirement, but there are different bits to the World Health Organisation surgical checklist. So by no means were we doing none of it, but we weren't really doing it 100% of the time in all attributes of it, because it's sort of the pre-surgical check, and there's different stages in it all. And I think there's a recognition that there's evidence that safety is enhanced, albeit, as I said before, there's no evidence here that we don't get outstanding outcomes. However, putting us at risk in the future if we're not following that maybe that would put our outstanding outcomes at risk. So although there's no direct evidence that not doing a WHO checklist here has led to any detrimental effect on patients, it is best practice, an expected standard, which we weren't meeting. And as I said before, we've turned that around. We are now meeting that. And I think in September we had an audit, 100% of cases. So yeah, we recognise that's best practice, needs to be done. I think we should also recognise that there's no evidence that the fact that we weren't doing it 100% of the time was having any impact whatsoever on patients.
Good. Okay, thank you for that. Now, one of the key CQC improvement points was that the service was not responsive to children and the young people's needs. Yet the redevelopment phase 1 would address the accommodation issues for the young people. So does this not put the trust in an impossible position where any improvement would require a better CQC rating to ensure funding, etc., yet the current rating prevents the hoped for progress on the redevelopment? Are we in a kind of a catch-22 situation?
So the RNOH has been in many catch-22 situations, and there are many variables that we have to navigate, and many of those variables are the reason why the estate is in the condition it's in, because, using a horrible phrase I've used before, in terms of getting our ducks all in a row, all of those things aligned at any particular, stars aligned at the right time, is a major challenge. Now, in direct answer to your question, so getting a good rating for the CQC was not a prerequisite for the funding for the rebuild. It is a prerequisite for getting Foundation Trust status. So in direct terms, it hasn't affected, because as long as we get a good before, we were going through an FT application, which was going to be next year anyway, that hasn't affected that directly. Obviously, we would have liked to have cleared that hurdle last year or this year, rather than having to clear it next year or later this year when they come back to do it. So I'm not claiming it has no effect, because that we would have liked to have cleared that hurdle sooner rather than had to do it in 2 stages
in 2014.
Indeed.
Yeah.
But the bottom line is that does affect our FT application. It doesn't in itself affect the redevelopment timetable that we've been following. Okay.
Now, outpatient clinics were reported as starting or running late, 26% at Stanmore and 21% at Bolsover Street. What's been done to address this?
Well, I mean, I'm pleased to say that the numbers come right down. I mean, and some of that's a technical adjustment and some of it's a real adjustment of paying. So the technical adjustment aspect is the way in which we were recording it, the fact that if you turned up to your appointment and went along to X-ray and then came back and that was and that you were the first patient that was being recorded as a late start, actually you were going along to radiology to have your... So we've tidied up how we count it, and we've also kept a close eye on it. And I think the latest figures, we're down to something like 6%, between 6 and 10% any particular month. I'm not saying that's there's more to do on getting that down to 0, but it's nothing like the scale that they found at the time of the inspection. Remembering this is about a late start, which I think is inexcusable. This isn't just about it's a busy clinic which overruns. It's particularly if you start on time, that gives you a hope of getting your patients through.
Yeah. So where now with the CQC report? I mean, you mentioned earlier that you're hoping to get them back. Is there a timetable for that? And are you optimistic that we'll get the satisfactory rating that we need?
So obviously the Care Quality Commission are an independent regulator. It is up to them, that they can turn up at any time for unannounced inspection for any reason, and they use a range of information to decide where they go and look at any particular time. The actual sort of formal policy is that within 6 months of their report, so that will be the 15th of February, if they return within that time frame between now and the 15th of February, they will, if it is for the purpose of the follow-up to the report, just look at the areas that required improvement. We're not going to have rebuilt the hospital by then, but we know that we can't get an outstanding rating overall without the making progress on the rebuild. However, by making progress on things like the WHO checklist, the clinic starts, some of the other things, we are able to get the rating up to a good. So if they arrive before the 15th of February, then they'll be looking at those areas. If it's after the 15th of February, it'll be a full inspection again, which again they can do at any time, but that's the general timetable of what we're looking at.
Okay, so fingers crossed.
But it's up to them.
Fingers crossed they get to us before.
Correct.
15th of February 15.
Well, I mean, if they don't, we're fairly happy. We've got a good hospital.
Yeah.
Anyway, so but I feel assured they will probably arrive before the 15th of February.
Right. Moving on to the redevelopment now. Given the recent developments, complications, if you like, with the CQC report. Are you beginning to lose faith that the RNOH has an independent future, and why does an independent future matter so much?
Well, I have never lost faith and will never lose faith that we will have specialist orthopaedic services in a Royal National Orthopaedic Hospital on the Stanmore site. I think that is a fixed point, as everybody I speak to describes it. So in terms of service provision, in terms of the site, I think that is a fixed point, and there's no alternative. There is no empty hospital that can take the Aspire Centre, 220 beds, 10 theatres. Where is this hospital? And so anybody who says, we're, inevitably at some point going to be moving this hospital somewhere else, doesn't live in the real world, because I've hunted high and low as to where that might be, and it does not exist. So I'm happy, and I haven't lost faith in that. Its location and the types of services that we provide are going to be needed. So we're all getting older, the ageing population, there are musculoskeletal health is important to the population of this country. You don't need a Royal National Orthopaedic Hospital at the end of every high street in every local health economy, but a national centre, tertiary academic centre that is leading the way, that the rest of the services in the country of orthopaedics are learning from. We're doing the research, we're doing the training, we're doing the teaching, we're doing the complex cases that elsewhere can't do, that will never be done in out of hospital in GP surgeries or whatever you believe about how much out of hospital care will be done. There'll always be a need for these services and the experts that we have here in Stanmore. Now, the independent status of the organisation, I think, will be a constant question. Does it matter? In some regards, yes. In some regards, no. It matters fundamentally that the autonomy of the clinical services, the focus on our patients, the focus on our areas of expertise is retained, and people believe that autonomy can get eroded if we become swallowed up in a bigger organisation or merged with other organisations. There are various examples over the years across the country, and for every example, one way you could quote me on how it all went wrong, I could quote you another example of how actually things got a bit better after those models. What is fundamental is that we retain the autonomy of the clinical services and the ring fence of the site, the elective centre. We are in a process which retains our independence. I can never guarantee that forevermore for the next 100 years. 15 years ago we were part of Camden Islington Health Authority, Bloomsbury Health Authority. The structures of the NHS change all the time. And to me, the concept of an independent organisation, what we're talking really about is an organisation that focuses on what we focus on here, keeps that focus, doesn't get deviated from that focus by some bigger organisation taking up and trying to sell off bits of the site, break up the services, etc. As long as that holds together, I haven't lost faith.
Great, good. One thing I always think is so important that often outsiders maybe overlook completely is the research and development that goes on here.
Well, I think that this organisation only exists and should only exist if it is a tertiary academic centre. So let me translate that. With our University College London partner who are on site, who are building a new academic centre. So for anybody who doubts that we're rebuilding the RNOH, why would University College London be investing 14 million on our site? Why would private providers be interested in building a private hospital on our site, and why are we spending £5 million-ish on a Princess Eugenie house on the site? These are real projects that are really happening on the Stanmore site, the roadworks that we've done and all of those sides of things. But fundamental to us is our academic partnership with University College London. This morning we were hosting the Dean, Professor David Lomas from UCL, who walked around the site, and every time he comes here he is astounded by what goes on here in terms of our biomedical engineering links, the medical technology that we're doing, some of the research we're doing, and we were looking at the Aspire Create and what we're doing for people with spinal cord injuries and exoskeletons and nerve stimulation and helping people restore their function. This is amazing stuff which doesn't take place anywhere else. I went to, I don't go on many conferences, so I'm not an overpaid chief executive who spends his life in conferences. I go on one every 2 years, and it's something called the International Society of Orthopaedic Centres. And this one was in Mexico City.
Wow.
And I stand in the bar in a hotel in Mexico City, and I have people from all over the world coming to me saying, oh yes, Stanmore, RNOH, we know that place. They can name the surgeons here, they can name the people that work here. And they know what they do, and they think it's amazing. So I think that's quite a impressive moment when you've flown 10 hours on a plane you're standing in a bar in Mexico City, and lots and lots of people are coming up to you from all over the world talking with high praise about what this place does. And all the more amazing what goes on when you look at the buildings, but inside those buildings, I know it's a cliche here, but it is amazing.
A world-class RNOH in a third world
Correct.
infrastructure.
Correct.
Yeah. Okay. Now, other NHS trusts have got into serious financial difficulty after having achieved Foundation Trust status and taken on the Private Finance Initiative, the PFI. How confident are you that this won't happen here at the RNOH?
So the first thing to say is the form of contract we are using for what we call the NHS Phase 1. As I said before, we're not doing this in one big bang. There are multiple projects, multiple things happening on the site. But the one that used to be known as PFI Phase 1 is not being done as a private finance initiative. And we are... the current business case has it as a publicly funded scheme with a long-term hard facilities management contract, so a long-term contract to look after the building.
So is that what we know as the old Phase 1, the
Correct.
90 million that was
Correct.
approved in spring 2010?
Correct.
Right.
So around about the last election, there was a full government approval of the outline business case. We have, and so that 90 million was made up of various things, which included some equipment, some fundraising money, and a PFI borrowing element. And what I'm saying is that now we're talking about, instead of borrowing around £40 million, we are funding around £40 million from public dividend capital and the land sale receipt from the Western Development Zone. So the form of funding is not private finance initiative, but the overall scale of developments that we have in the master plan remains the same. The initial phase has had to be scaled down a bit to allow that to keep moving forward. The most fundamental one of which is we are, instead of having spinal cord injury centre in there, we're obviously focusing on the new children's unit with the CQC's concerns about that as being priority number one and its isolation from the rest of the hospital. Imaging and a few more adult beds on top of that as the balancing item, if you like, in that equation. Spinal cord injury, keeping it where it is, but refurbishing it and expanding it rather than sort of waiting for this new building. So they're, from their point of view, disappointed they're not in the new building, but excited by, actually that means if they're not going to be in that first phase, we can focus on doing some work in expanding where they are currently located, which is not a bad facility. It's part of the site that is not too bad, and that pathway through to the Aspire Centre in terms of how the patient flow works fine. The new Princess Eugenie House, etc., will be over with replacing Graham Hill House and all around there. So it works okay in terms of the overall master plan. And if anything, allows them to get on with some of the work now rather than wait for the new centre to be open in 3 years' time.
Because obviously SCIC is one of probably the newest ward block that we've got on the site, and that's 30-ish years old, I think. So,
Indeed. So that's the idea behind that, is that we focus on getting a new children's unit and imaging, which is really short of space and appropriate space, those two areas, and then gradually replace the rest of the adult wards in blocks in where we have the planning permission for the new hospital.
There are now even more ways to listen to Radio Brockley. Tune in on 999 AM from your radio. Catch us on Channel 1 on your bedside headsets. And now tune in online via Wi-Fi Spark from your laptop, smartphone and tablet. Even more ways to get Radio Brockley when and where you want it.
Now let's hear part 2 of Keith Reeves' interview with the hospital's chief executive, Rob Hurd.
So what's the situation with a prospective new private hospital on site, and how do the present private wards fit into those plans? Because I know that at the moment, I think a lot of the private work's undertaken at the Spire Hospital at Bushy.
Yeah.
And I think there are designs to bring some of that work in-house. Yeah,
well, I mean, we are formally in competitive dialogue with private sector partners who are working with us on proposals. It's in the northernmost bit of the site in terms of planning permission, separate from the NHS, and that competitive dialogue, we're due to select a preferred bidder when we have initial sort of proposals in response. I mean, it started last January, but final proposals will come in February of 2015, and we would hope to sort of sign a preferred bidder shortly after that and begin the work on the project next year. So that's a very exciting project that is reaching, a conclusion, not dependent on the same sort of layers of approvals of the NHS bit, because this is really saying we're generating a bit of income privately in our wards at the moment, and this is trying to expand it. So we can only gain it from that when we're not putting at risk. But what more contribution can we get to the NHS? Rather than putting any services at risk.
So would that be, you say it's a separate facility, separate building?
Yep.
So could that possibly be built before phase one even of the redevelopment?
One we're pushing to happen quickest is University College and Academic Centre, because that frees up the Western Development Zone and things like replacing staff accommodation, because that's the sale we need to make to have a cash injection in 2017 to pay for NHS phase one. Therefore, the two should be happening effectively alongside each other, and I would envisage that they'll be sort of signed off over a similar time scale. It may even be when construction contracts are being awarded, for example, as the private hospital would be, maybe the people who are interested in constructing the NHS bit will also be interested in the private bit. So in my ideal world, it all comes together in these different phases, being, and achieving economies of scale with one builder on the site doing different bits to it. But that's, going back to my previous comments about ducks in a row and different variables, that's quite challenging to achieve. But I would hope as much as possible happening at the same time, to have as much as possible finished at a similar time, so we're moving from old facilities into new facilities at a similar time.
So I suppose the bottom line is, and I think you've mentioned there about 2017 in paying some of the NHS bills, etc.
Yep.
Are we still on track to be opening a new hospital in summer 2016?
So clearly that date is, in terms of a new hospital, is not going to happen in terms of what we were envisaging at the time when we set that date. However, there are new things happening on the site. And I think, as far as I'm concerned, as I said earlier, we've been here 100 years. I think we'll be here another 100 years. The scale of building that goes up in any particular years, I challenge anybody to say with any certainty around that. But we're moving forward. We've just opened a new theatre. I think the Princess Eugenie House building will be going up next year. We're in final planning permission on that. So we had the outline planning permission last year. Final planning now going through. Money in the bank. It'll happen next year. So will it be up and running in 2016? That's going to be tight. But I think you're looking at 2016, 2017 for the first phases of major buildings going up. But those major buildings are not as major as what was envisaged a few years ago, as solve the whole problem with £250 million, which we can't afford. So I think it's very much a piecemeal, incremental development. Because the alternative, I know that'll be frustrating for people, the alternative of doing it in big bangs leaves the organisation under threat. Are we viable? Would we be taken over and lose all the stuff that's important that I talked about earlier?
Right, we're gonna move on to the current hospital now. Now, the RNOH was recently ranked in the top 100 places to work in healthcare. Yet the CQC report raised some high levels of bullying and harassment amongst the staff. How can these two views be so different?
I think they come from different places in the sense that we have fantastic staff at the RNOH. And what they report, so the thing the CQC look at, like the staff survey, like our friends and family, so just to quote you, they've done the first set of, published the first set of friends and family feedback from staff reported feedback on the hospital in which they work. And the RNOH was second in the country, of all hospitals in the country, of staff recommending us as a place to have treatment.
That's tremendous. And
was 8th in the country as staff recommending us as a place to work. And as you say, we were awarded 100 best place, we're in the top 100. So there is lots that people themselves say, not just me, say that it's a great place to work and it's a great place to have treatment, that people report that. Now, bullying and harassment in a close family, community that we have at RNOH is not acceptable. We do have examples of the inappropriate behaviour at times, and we've been going through a process, what called our organisational development programme, to stamp out the worst excesses of behaviour. But I think whilst it feels incompatible, I think if you are aware of what the Trust is doing, what we're trying to do, we've almost sort of exposed more of it by having a focus on it, the bullying and harassment side of things. And the CQC were entirely, they looked at everything we're doing and said we're doing all the right things. The proof of the pudding's in the eating. When we get a staff survey saying people aren't reporting, or you're going into theatres or on the wards and saying, no, this isn't taking place. So I think it's a complex issue because the perception of bullying and harassment it is a question for every, what you would describe as bullying and harassment, another person describes as something else.
Yeah.
So all in all, I think it is something we're working on. We're recognising there are examples of inappropriate behaviour, and we're trying to deal with that in a positive and constructive way. And people need to feel out there that they know who to go to, and we've done a lot around sort of telling people who to go to. If you don't feel safe going to your line manager or to your staff representative, there are phone lines there are staff support groups. There's a lot of places to go for help. Because I know in the stresses and strains of trying to achieve a work-life balance, it can get quite stressful. We're doing great work for patients. We would recommend it for some, but it can be quite stressful dealing with colleagues at times.
Yep. And
you need places to go for help, and there are places out there, and that's publicised throughout the hospital on the website. And so I think it's there, and I think we're making good progress. And I'd hope the next staff survey shows that progress.
Now, the NHS budgets for 2015-16 look unachievable. How will this impact the RNOH? Will there be further cuts needed, economies?
Well, I go back to our sort of my comment earlier about our role in the country and the world as a national centre. So whilst, yes, anybody who reads the papers knows that healthcare in this country and around the planet actually demand continues. There's more that we can do for people. There's an ageing population in the Western world, and there are only limited resources in whatever healthcare system that you've got. And to be fair, the National Health Service, when rated against any other system in the world, comes out top. So we're very equitable. We have access to our services, and actually, when you need the NHS in an emergency, I think it provides a pretty good service. And I know there's a lot of press around A&E targets and a lot of NHS bashing that goes on, but I would urge people to actually step back and say, how does it compare with other countries? When people have looked at this academically, they would say it compares actually very well. Now, in detail, there are still problems, and we're all trying to fix those and move on. And the daily experience of a service that is under pressure, I do not deny. We're going through a winter where a lot of hospitals are under a significant amount of pressure, and when you've got constantly rising demand within limited resources, or resources that are not matching that, you're going to have a tension there between the two. The RNOH's role is to be a leader of quality, because quality actually is best value for money. And we can demonstrate that actually by getting it right first time in orthopaedics, which is a project we've been heavily involved with and working with other orthopaedic centres, creating networks, by getting your operation right first time, not having readmission, not having an infection, which costs a lot of money. Patients are happier, taxpayers happier, because it's cost us all less money. And that academic side I talked about earlier, innovation, best ways of doing things. Is all surgery appropriate? Are there, is the expensive option actually the best option? And these are all important decisions about the future of our health service, because whether we like it or not, resources are finite and demand is pretty unlimited for healthcare, and we need to play a role in balancing those two things, but quality at the heart of everything we do, because if you're providing a good service, it's actually a more efficient and better value service.
Yeah, it goes without saying, really. Because I think the getting it right first time was a Tim Briggs initiative.
Correct,
I think.
yes.
And he took that to Parliament. I think, was it last year?
Correct. So we Tim attracted a grant for that, and I went to 120 hospitals with him and bailed out. He carried on to, I think, nearly 200 across England.
Wow.
And actually over the next few weeks we're going to be doing Wales as well, because we've been commissioned to do that project as well. But in essence, yes, the NHS England and Department of Health Secretary of State commissioned this. The report is currently with Department of Health and Secretary of State, because we come to the end of his year as President of the British Orthopaedic Association, and that's going to be shortly going out into the public domain about the findings of that report. But in essence, the themes are around, variation in practice, that if we could get, consolidate activity, critical mass of people doing a lot of something, doing it well, that doesn't necessarily mean do all your routine hip replacements in Stanmore. In fact, it's the opposite, but get local hospitals that are doing a lot of it, rather than dabbling in surgery. Use the right implants, use evidence in practice, reduce that variation to effectively improve outcomes, which means patients are happier and the taxpayers happier.
So what are the Trust's fundraising plans for 2015? I think the RNOH charity has still got its £15 million target.
Yep.
Any new ideas coming along?
Well, the immediate focus has been around getting Princess Eugenie House, fully funded, because obviously we've had support from the Sick Children's Trust for an element of that, and other elements that are funded by the charity and that have been fundraising for. The other immediate imperatives are around equipping the hospital and the new, because obviously orthopaedics is intensive. A lot of our kit is quite old, and we need, particularly in imaging and some of our theatre equipment, to keep that really up to date, and getting support from the charity on that is the immediate imperative. We're actually agreeing a sort of a 5-year plan with the charity around because what we don't want to do is sort of fundraise for buildings that never happen, and so we Prince Eugenie House, that's definitely, it's going up very soon, so that's the immediate priority, getting the equipment funded, because we know even if the building's not quite ready, we need the equipment. And then particular campaigns as each building, as the pictures start to emerge and people can start to feel it going up, then it becomes real. But we've taken a bit of a different approach, rather than we're trying to take a different approach rather than fundraising for something, 15 million at some point in the next 10 years.
So more of a hand-to-mouth approach for the immediate future than something that's holistic.
Exactly. Still a target of 15 million, but focusing within that at any particular time on particular strands.
Now, this is a question that came from one of the people that are members of the patient group here. Do you think there is enough liaison between the clinicians and the management, and how do you ensure that there is adequate consultation with all parties before any significant decision is made?
For me, it's a very obvious answer. Any decision that is made in this organisation is made shoulder to shoulder with a clinician. So that happens, at board level, we've got a medical director, a nurse director, an ops director, and the other directors supporting that, and then a division within the hospital has a clinical director, a manager, and a lead nurse, and a unit will have a clinical lead, a service manager, and a nurse that supports that unit. So in terms of when a significant decision is made, that is made in partnership. And we have about 85 consultants, if this is around, but we also have a large number of allied health professionals, and obviously our nurses. And all of those groups, depending on which particular issue we're talking about, do have forums to engage. It's always a challenge when people are busy doing the day job looking after patients to communicate. We try through team brief. We try and encourage departmental team briefs, say what's going on in the wider hospital. I have a group called the Staff Champions, where I try and translate from my management speak into how would staff see this, and the different staff groups to take out into their constituencies, if you like, to talk about what the hospital is trying to achieve and turn it into the language of people on the ground. Now, adequate consultation with all parties, you're never going to win on every aspect of that, because there are difficult prioritisation decisions that need to be made. Everybody would tell you, the doctors themselves, you do not design a building. People who design buildings should design buildings. You need to consult with what the building needs to achieve with the users of that service, and neither should you just design a building for the architects and so you have to have a balance between all these things, and ultimately somebody has to make a decision that balances all the different viewpoints up. And we sit as an executive team every 7:30 every Wednesday morning, and around the table are clinical directors, consultants, managers, a nurse, a therapist, and that's where we make our decisions. So it's the question implies there may not be the liaison. That's what I'm doing every day of my working life.
So the structure's there and it is used?
Yes, absolutely.
Now, big question here, affects me because I volunteer in various forms at this hospital, and there's many others like me. What is the future of the various charities associated with the RNOH after the new hospital is built? And many of them, like the Disability Foundation, Barbara Bus Fund, Radio Brockley, survive on a shoestring, occupy old buildings at zero or low cost. So how will we all fit into this commercial environment that new hospitals have to operate in?
Well, I think the jury's out on some aspects of this, as you know yourself, Keith, in terms of the world of charities and the drive towards bigger charities that can self-sustain themselves with all the bureaucracy you need these days for charities. So it's tough for small charities in the modern world to keep going. Look, and also on this point about the commercial environment of the new hospital, we sort of cross that bridge when we come to it, don't we? I mean, I think we're not throwing anybody out at this point in time. When it comes to the point at which that is happening, yes, I mean we have been in discussion with the Disability Foundation about can we find an economical solution for them? Not put them into the most expensive new building in the hospital and charge them a fortune, which means they can't do their role. But is there another bit of the hospital that's spare for them to sit in? It's not going to be luxurious, but it's going to be there. So I think all I can really say is we value these partnerships. We recognise there is a changing environment around them and how some of it might need to get to sort of critical mass, and we will work case by case on how we can find a home for them.
Right. Fingers crossed then.
Yeah. We're not throwing anybody out.
That's good. That's good to hear. Very reassuring. Thank you. Now, the Patient Choice Award is new for 2014. There's been staff awards at the RNOH for several years, but this year a new one where the patients can actually nominate candidates from their nursing care experiences here. How did that come about? Because it's a great idea.
Well, I mean, you'll be aware that the involvement of patients more and more is, it sounds obvious, doesn't it now? And I think we've had a very active patient group at the RNOH for many years. They attend the board, involved in all sorts of things here, and you've been a major part in some of that, Keith, yourself. But the partnership forum that we have with our staff, when we were talking about the Staff Achievement Awards this year, and should we do it the same as always, do anything different, etc. And this was a suggestion that came from staff, in full knowledge of the environment I've talked about, is when we encourage more and more to involve patients. It sounds very obvious now, doesn't it? But getting patients to nominate that, because at the end of the day, the patients are what we're here for. So I think it's a very good idea. Came from staff.
Great.
In the partnership forum that we have with staff, and we're trying it out this year.
This is Hospital Radio Brockley. It's a very special edition of Brockley News Extra as we hear from the hospital's chief executive, Rob Hurd. Here's part 3 of the interview now with our reporter, Keith Reid.
Now, I understand also that the funding for the shuttle bus was under review, as was the service itself. There was a survey went round a couple of months ago about this. What was the outcome of that?
We have used the results of a survey because we're buying a new contract from the 1st of April next year for a shuttle bus service, and the idea of the survey was to inform what we were going to ask for in our new contract. And it was also a subject matter I talked about with these staff champions that I was talking about earlier, what the view on this is, because it's an interesting area, because obviously fundamentally we're a difficult site to get to. A service that allows people to get up Brockley Hill and from the local tube stations, etc., is essential. And if anything, we want to turn this in, as I talked earlier, with an academic campus, more undergraduate students coming to the site, getting much more activity on the site as a place to visit. That all lends itself to, obviously, we want to bring people to the site. It costs us £90,000 a year in a world that I was describing earlier as a problem, and to attract staff here, we recognise the value in that. So we're going to look at increasing frequency, not eliminating it. But when you're making difficult decisions about what you can and can't do, ultimately those decisions also have to take into account what are we ultimately here to do, and how many nurses on the wards versus the shuttle bus service is very difficult to prioritise. And so I think it's very easy to construct an argument for why we need a shuttle bus service, why we need more shuttle bus service in there. Of course, and I'd like the world to be a wonderful place that does everything, but we have to make those difficult decisions. In that process, we are, if anything, increasing and improving it, which I'm sure people will think is the right decision. But I think we also have to be open and transparent. As I said to the staff champions when I talked about this, what would you do if you had £90,000 to spend for the RNOH on and getting people to this site and making it easier to navigate to the site, and when you get on the site, finding where you need to get to, would you spend that on a shuttle bus service? And I think that we've ended up with the answer yes, because we can't think of any other answer.
Right. There was a talk of charging a nominal fee. I think it was £1 a trip, because at the moment it's free. Yep. Is that going to happen?
So there's licensing issues for that. As with all charging, administration costs come with that, so you're always weighing up, does it cost you £100,000 to generate £101,000, and is it really worth it, sort of equation. I wouldn't deny there may have been discussions, is that an option, but there's no serious plans at this stage to implement that, simply because it hasn't been worked up effectively at this point, and I don't think relative to anything else that's certainly not happening this year. When we go through our planning rounds in future years, as I said before, nothing can be discounted because you're having to make some quite difficult prioritisation decisions. But at the moment, if my gut feel on it is it'll cost a lot to administer, and therefore is it worth it relative to some of the other things we can do.
Now, the RNOH is has actually appointed a voluntary services coordinator. So what are your views for expanded roles for volunteers here at the RNOH?
Well, I think it's a great resource here that is both tapped and untapped. So there is some really good work that takes place by the volunteers at RNOH. I think by having a coordinator, we will be able to sort of have some thoughts about, right, what are we all here to do? What are the volunteers here to do? Are we achieving that? How can we coordinate the different groups that are involved in those activities? What are those different groups targeted at? And can we sort of get a critical mass of support taking us in the right direction? And I certainly think, that goodwill that we get and the goodwill towards the organisation, we should nurture. I think the investment, I think the charity funding this, so very grateful to them. Again, going back to my previous point, you could easily construct an argument that actually the value that we get out of volunteers, the RNOH should be paying. I'm sure we should be paying for everything, but something has to give in the challenges of prioritisation that we face. So that they're grateful to the charity for that. Part of the role of the volunteers coordinator is to establish how the volunteers coordinator is going to operate in their initial period. His initial period will be doing a stock take of going around meeting us all, listening to our views, working out how that's going to work in the future. And so I think it's about taking something that's good and making it better by coordinating it more effectively and having everybody aligned in the same direction.
Yeah. Final question the serious questions anyway. How are the plans to open the hospital 7 days a week progressing?
Some people would say we're in some areas we're open 7 days a week already. The constraining factors of this really are, it's what we're talking about is, are we as safe and are we doing all the same activities on a Sunday as we do on a Monday? And I think we're a long way off. Well, we're certainly safe on both days. We're a long way off it being equivalent to that. Now we do a lot of activity. We do a lot of surgery on a Saturday, sometimes on a Sunday here. And we, 7 day working across allied health professionals, physio, OT, etc. The pockets of that coming through. Pharmacy, doing more on a Saturday, some of the support infrastructure. Now, we're having a proper look at this, though, in terms of across the trust and all the different elements, because for want of anything else, we're required to do so in submitting plans in December. My concern with it is, nationally, there is this assumption that somehow we can become 7 day without it costing any more money. And I think we need to be very clear what we can do across 7 days and what is actually an additional resource requirement, which is good for patients. But just assuming that you can smooth everything out across 7 days and spend the same amount of money that you do at the moment, I think is going to be difficult. But certainly the important things like ward rounds on a Saturday and Sunday, people making sure that Saturday and Sunday is as safe as the rest of the week, I think we're doing that anyway. The additional sort of, are we doing exactly the same things in terms of what numbers of operations and cover arrangements for those on a Saturday and Sunday and a Monday? No, because that requires a lot of work before we get to that point.
Will you be pleased to know that's the end of the serious questions? Thank you very much. A couple of little things here. First of all, how did you become the chief executive of the RNOH?
So I came here 8 years ago, believe it or not, Keith, as the finance director, and there were a few financial difficulties back then. Although we didn't, turn the finances around so that we got a £200 million new hospital built. I thought I'd come along and spend a couple of years sorting it out. The new hospital would go off, and I'd go on to greater things elsewhere. Unfortunately, I've gone completely native. I came here. Was then 2 or 3 years after being the finance director, went for the chief executive job when my predecessor left, and I believe in the place, and that's what's kept me here, because I think excellence in the NHS in centres like this is something that needs to be protected in a difficult world when I totally understand the other priorities of the NHS, but somebody's got to stand more and what we do well here and navigate a way through the very difficult environment that faces us. Some people, like I said, when I talked earlier about talking to people in Mexico, they don't understand, how does the UK let its National Orthopaedic Centre get into this state? I understand it. Some of it's our own fault, and we need to change that. We need to get out more. We need to show that we're the National Centre of Excellence, not sit in Fortress Stanmore and do complicated operations and expect the world to come to us and save us. We need to get out more, and we need to build that academic partnership I talked about. So I have gone native, and I believe in that vision, that tertiary academic centre with more private activity, because we have a privilege here of being an elective ring fence, no A&E department. We can bring the interesting cases, we can subspecialise, we can be good at what we do, and that is a privilege to do that. We need to repay that privilege by being the place to innovate, to come up with a new treatment, get in the interests of patients. And the health service is more and more bankrupt, so putting a private hospital around, which is going to keep our doctors on the site, not off in other private hospitals, I think that's all part of the price we have to pay. Selling a bit of land, all part of the price we have to pay to survive as an organisation. So that I came here thinking I'd sort of help on my own career path and move on to other things. I'm staying here till it's solved.
Good to hear. You're like a lot of us, I think. You have a sort of an initial contact as either a member of staff or, in my case, initially as a patient, and you're still here.
Yep.
You get stuck. Now, it must be a very stressful position. I know I see you from time to time, and you always look in a rush. You often have got a cold, and you're trying to shrug it off and put a brave face on. How do you relax? How do you switch off?
Well, unfortunately, I have a very young family, Keith. I have 18-month-old twins and a 4-year-old. So work is my relaxation. So when I go home, that's when it gets stressful. No, seriously, I mean, my family life is obviously very important to me, and is fantastic escape from the end of a stressful day. To have that total change, no choice. You've got to switch off. You've got to deal with the children, and that's great. So that's I used to have sporting activities and other social activities, but young family has destroyed all of that. I'm very much a family man now, with occasional time for a bit of five-a-side football and squash and that sort of thing, but not much.
Okay, great. Cheeky question. Have you ever listened to Radio Brockley?
So, I read this question and I thought, what do I do here? And I thought, I'm going to listen to Radio Brockley before, because I hadn't, when I read this question, I thought I'm going to listen to it.
Right.
And the honest answer is, I haven't yet. I have listened to I've downloaded individual program files.
Oh, from YouTube.
So yes, and I think off the website as well. You can do.
Yes, there's a link through from there.
The link. So I've listened to snippets in the sense of that. Listening to my last interview, and then when I was looking at it, this is a few weeks ago, or maybe months ago now, listened to a couple of other things just out of interest. But no, other than listening to downloading a couple of snippets. I'm not a regular.
I think that counts. That's okay.
Yeah. I thought I'd better just, if in doubt, be honest.
Thank you. Rob, thank you very much for your time once again. And we know it, as I said at the beginning of the interview, we know it's precious. Very, very grateful that you spare us this time. Thank you, and please keep up the good work.
Thank you very much for having me, Keith.
Pleasure. My thanks go to Ron Laver for studio operation during the interview, and the interview was edited by myself, Keith Reeve. Thank you for listening.
Massive thanks once again to the hospital's chief executive, Rob Hurd, for that interview with our reporter, Keith Reeve. If you want to catch up on that and other previous editions of Brockley News and Brockley News Extra, you can do by logging onto our website at radiobrockley.org and following the links to our YouTube site. And if there's anything else happening here in the hospital that you want to know more about, you can contact us on extension 5483, and we'll try and cover it on future editions of Brockley News and Brockley News Extra. Stay tuned to Radio Brockley across the week for more information about the events and services available in the hospital, along with the widest range of music you'll ever hear to suit all tastes. And of course, you can catch Brockley News Extra on Radio Brockley Monday evenings and Monday to Friday lunchtimes at midday. You can also tune into Brockley News every Sunday for half an hour just before bedside bingo. From me, Alan Joyce, goodbye.